Hello, everyone. My name's Dr. Santoli. I'm a resident at HCA Florida Blake Hospital, and this is a presentation on Metformin Lactic Acidosis. I performed this research with the help of Hossein Tahiti DO and Jamie Lee Aldecour DO. Introduction. Lactic acidosis is rare, but it's extremely serious complication of metformin use. It's a major toxicity concern with biguanide use and the reason fenformin was removed from the US market in 1976. The mechanism of metformin lactic acidosis includes conversion of glucose to lactate in the splanchnic bed of the small intestine, as well as inhibition of mitochondrial respiration, which leads to decreased gluconeogenesis. For our case presentation, we had a 62-year-old male with a history of type 2 diabetes, CAD status post 6 stents, and essential hypertension. He came into the emergency room with weakness, fatigue, multiple episodes of nausea, vomiting, abdominal pain, and decreased urine output for several days. Of note, he had been working on a roof, doing roofing work for 3 days prior, and had been out the entire day without consuming very much water. For his medications, he was on amlodipine, aspirin, atorvastatin, clopidogrel, and metformin 1000 milligrams BID. None of these medications were new. For his vitals and physical, he was hypertensive at about 160/90 with moderate distress secondary to abdominal pain. He was diaphoretic. He had voluntary guarding of the abdomen, but he had no abdominal tenderness in any of his quadrants. He had no rebound or other peritoneal signs. On his initial testing, he had a potassium 6.4, his lactic acid was 11.7, blood glucose 20, creatinine 13.3, and an ABG ordered at that time after bicarb was also found to be low, showed pH 6.9, PCO2 25, and bicarb of 5. His CT abdomen pelvis was done and was negative for any acute finding. His management, initially he was given calcium gluconate 1 gram IV, 2 amps of bicarb plus started on a drip, and eventually he was intubated mechanically ventilated when he decompensated and had altered mental status and inability to protect airway. After that, he was given emergent dialysis. This treatment led to rapid reversal of acidosis and hyperkalemia, and the patient was discharged 3 days later with metformin discontinued. For the discussion, metformin lactic acidosis occurred in 4.3 cases per 100,000 patient years, so it's quite rare. Mortality can be up to 45%, and best predictor is liver dysfunction, which increases the lactate because of decreased ability to break down lactate. The symptoms are most commonly nausea and vomiting. Less commonly, patients have dyspnea and altered mental status. The best things to check is a blood glucose, a Tylenol level, salicylate level, EKG, beta-HCG in women of childbearing age, ABG, CMP, and lactate. Metformin levels are not needed in these patients. The most common patients that present with this are patients with pre-existing hepatic insufficiency, renal failure, as in this patient, acute infection, alcohol use, prior lactic acidosis with metformin, hemodynamic instability, hypoxic state, and or severe illness. And below is an EKG that highlights peak T waves in a patient with hyperkalemia. This is from his EKG done in the emergency department. For management, in addition to the ABCs that you would do, airway, breathing, circulation, acidosis must be treated with bicarb if pH is less than 7.1 or if it's less than 7.2 in patients with a severe AKI. The goal is to maintain a pH above 7.1 in normal patients and more than 7.3 in those with AKI. Dialysis should be used in the following cases: lactate 15 to 20 millimole per liter, a pH less than 7.1 or 7.1, shock, vasopressor therapy, or AKI with a creatinine above 2.0. Metformin should be discontinued and patients should follow up with the PCP within 6 days to modify hypoglycemic therapy. In conclusion, the objective is to discuss the importance of rapid recognition of metformin-induced lactic acidosis in patients without history of renal or hepatic failure. Proper treatment with emergent dialysis and bicarb is potentially life-saving. Elevated plasma metformin concentration, e.g. in kidney failure or other events that interfere with lactate production or clearance such as hepatic failure, sepsis, are typically the factors that lead to metformin-induced lactic acidosis. However, as discussed, our patient had no history of such events. Thank you very much.